All right. Thank you, everyone, for joining us for today's Lunch and Learn, which is all about falls. Now, you guys have been asking for us to put a webinar on about falls for some time now, so we're super pleased to be able to do that for you. A little bit of housekeeping before we start. We are expecting a lot of people on this call, so if you're jumping in, please pop yourself on mute so we can't hear your conversations, and please feel free to use the chat. Thank you. Awesome. If you haven't been to one of our lunch and learns before, I am Kate Lamont, Director at Thrive Aged Care Consultants, along with Kath Kirby, who's busy letting everyone in from the waiting room. And together we support teams that work with older people. Yep, through providing education like today's session, working with teams for service support and improvement, and also mentoring. So thanks for having us. Thanks for jumping on for today's webinar. Now, I'd love to introduce you to Amy Crimes or Amy Parker. Where I've known her as both. I've known Amy for a long time. Amy is leading today's webinar, and Amy is a physiotherapist with expertise in quality improvement, in research, in project management, and in health services leadership. Amy was recently with NARI, the National Aging Research Institute. Oh my God, Amy, that's a mouthful. Amy's recently come from NARI, where part of her role was really translating research into practice. And that's what today's about, taking research around falls and best practice and supporting you guys with strategies that you can roll out at your own services. So I'm going to hand over to Amy now to start today's webinar. Thanks, Amy.
Oh, you're on mute.
And take control of the presentation, Amy. We're joking about this. I like control, but it's yours now.
Oh, Kath, can you load it again for me to take control, please? Kath, can you hear me? Oh, you can. Excellent. Can you load it again? I've lost the take control button.
There you go. You got that. Can you see the presentation?
No.
Would you like, I'll move the slides for you. Can you see it presenting?
No. Hang on a second. Maybe I'll try a different view. Sorry, everyone.
Doesn't matter how much you check IT.
I know. We just did it about 3 times. I cannot see the presentation.
Can you see the presentation, Kate? Yeah. Amy, have you got the presentation in front of you and I can move the slides for you?
Yeah.
Yep.
Let me do that. Talk amongst yourselves, everyone. We just sort this one out.
We had a record number of registration. We actually booked out registrations for this topic. So clearly there's a lot of interest and there's still people jumping in. So just give us 1 minute. We sort our tech.
That works well for the latecomers anyway.
Yeah.
Okie dokie. So I'm going to be working blind because I can see my presentation, but I can't see what you're seeing. So please let me know if things are out of sync.
Yep. Let me know when you want me to move slides.
Okay.
Off you go.
I will. Okay. So thanks, everyone. Thanks for your patience. And thank you so much, Kate and Kathy, for having me here today to talk about a topic that I know has been around for a long time, and I think unfortunately will always be around, but certainly good to see that there are some updates and some guidance coming out to support residential aged care in helping to prevent falls and also prevent injury from falls. So today's session as to why we're here. So as we know, falls remain the leading cause of preventable harm in aged care. However, there are some best practice guidelines that have been released last year. Those guidelines cover hospital settings, community settings, and also residential aged care service settings. So the idea behind today's session is really to have a chat about what's changed in the updated falls guidelines, how the new guidelines align with the Aged Care Quality Standards, the Aged Care Act, and the National Aged Care Quality Indicators, and just to give you some tips around what you can do today to prevent your residents from falling and sustaining injuries. All right, Kath, let's go to the next one. So I think, a definition of falls is always a little bit contentious and up for debate, but we've got one that's up here now. So a fall defined as an event that results in a person coming to rest inadvertently on the ground or floor or lower level. So that can include falls from a low bed and onto a crash mat. And we know that falls can result in major injuries. Obviously, there's a number of injuries that are listed there that meet the category of what's considered a major fall. Around 30 to 50% of residents in residential aged care fall each year, and it's estimated up to about 40% experience recurrent falls, with 10% sustaining an injury that does require hospital or emergency department attention. So we know that recent Australian research has found that in 2021, 2022, falls injuries accounted for 20% of annual expenditure on an aged care resident. The average cost of a fall resulting in injury was around $2,500. So that really means that the potential cost of fall injuries to Australia's healthcare system is estimated to be around $325 million a year. Thanks, Kathy. So we're just going to take a minute now to have a bit of a think about a recent fall that you might have either seen or reviewed in your workplace, and just to have a bit of a think about what might have made it preventable. We know that while not all falls can be prevented, the evidence does suggest that falls rate can be reduced. So if you've got some thoughts got an image in your mind as to a recent fall or something that you've heard about, please pop in the chat now. Anything that you can think of that might have made it preventable. Kathy and Kate, I'm going to get you to monitor the chat for me and let me know what's in there.
Yep.
Any entries?
I think people are thinking and typing.
I'm sure Kate's got a thought.
Hey,
Kate?
I was going to say, Kate's jumped in already. A low chair.
A low chair, yep.
Yeah. Was that contributing, Kate? Yeah. Better dressing, undressing strategy in the toilet, wrong footwear.
Yep. The image is giving some clues, isn't it?
Oh, footwear's come up again. Fell off a chair which had wheels that rolled away from under me. This is a stuff fall.
Oh, no.
Unmet need. Oh, yes. Someone's continence. I'm going to jump in. Yeah, continence is the most underestimated risk factor for falls, I think, in my opinion, Amy. I don't know if you agree. Yep.
Yeah, absolutely. Absolutely up there, for sure.
Yep. Staff rushing, better monitoring and support for cognitively impaired clients unable to adhere to recommendations, medication, trip hazard, cluttered spaces, clients falling out of wheelchairs. Lots of answers there.
Yep,
there you go,
absolutely,
Amy.
absolutely, fantastic. So we're going to talk about some of the things that do make falls preventable, but thank you very much for popping those in the chat, and hopefully by the end of the session you might have some more ideas as to things that we can do to obviously reduce preventable factors in influencing falls. So here we have the copies of the new guidelines. So as I said, there are guidelines for hospitals, for residential aged care, but also for community care. These guidelines are Australia's national evidence-based framework for reducing falls and fall-related injuries. And they were developed with the aim of reducing preventable harm, improving safety and quality of care, and providing a consistent national standard to ensure that older people experience the same level of safety, whether they're at home, in hospital, or in aged care, and that providers across Australia are aligned with the same evidence base. And these are available online. We've got a link later if you'd like to have a look at them in more detail. So before we move on, just a little quick one this time. So again, in the chat, if you could just pop on a scale of 1 to 5, how familiar you are currently with the Australian Falls Guidelines. So 1 would be that you're not familiar at all with them, 2, that you're not really that familiar, 3, neutral, 4, that you're quite familiar, and 5, that you're highly familiar and the guidelines are sitting by your bedside at night.
Yeah.
Maybe not.
So we've lots
sorry,
of
go, Kate.
twos, lots of
Yep.
twos, some 3s coming through, a couple of 4s, sitting in the middle, I think.
Yep, absolutely. All right, well, let's have a look at them. So the Falls Guidelines for Residential Aged Care outline both recommendations and good practice points for implementing person-centred fall prevention interventions based on both personal and environmental risk factors for falls. So many of these risk factors, which also double as potential fall prevention interventions, can be modified in an attempt to reduce falls and improve outcomes. So obviously some of the ideas or the thoughts that people had previously around things that might have prevented falls are probably on that list. Kathy, you've got continence is on the list, but there's obviously quite a few different factors that we can actually look at when we're considering how we might prevent falls. So the recommendations in the guidelines, next slide if you're not there, Kathy, are based on evidence from intervention trials in residential care with falls and or falls injuries as outcomes. So you can see here that number 1 indicates a strong recommendation, 2 would be a weak or a conditional recommendation, and then the rating of A, B or C indicates high, intermediate and low quality evidence respectively. It is important to notice that not all of the different areas contain recommendations. So there are obviously some cases where no quality studies were available for interventions. And in these cases, that's where the good practice points come into play. So the good practice points guide the aspects of care of older people, and they're based on research, but more importantly, expert opinion on best practice. So in terms of updates for the initial guidelines obviously were written a number of years ago, and this is obviously an update. So the 2025 guidelines do represent a major shift towards a more personalised and proactive approach. So it's really moving away from the generic risk scoring tools and really looking at tailored evidence-based interventions. And obviously this aligns with the strengthened aged care quality standards that are mandatory and really critical in ensuring safe, quality person-centred care for older Australians. So as I just mentioned, the emphasis on the importance of implementing appropriate fall prevention interventions to address falls risk rather than just assessing falls risk. The advice really is that all residents should be considered at risk of falling in residential aged care. There's much stronger evidence for the ongoing delivery of exercise for fall prevention, and we'll talk about that in a minute. There's a new recommendation, which is around involving a dietitian in menu design to ensure that menus meet daily nutrition requirements for both protein and calcium. There are expanded good practice points, as we said, based on expert opinion. Stronger emphasis on balancing safety with a resident's autonomy, and that's supported by shared decision making. And as I said, integration with the strengthened aged care quality standards. So building on what we just talked about and what you put in the chat earlier, I've got a little image here, and this is actually that you can see the website there that this is taken from. It's actually the website that the guidelines can be found. But the idea is really to look at that image and have a think about the risk factors with some visual prompts And again, if you could just pop in the chat things that you're seeing there or that prompt you to think about aspects that could help to avoid or prevent a fall or an injury from a fall. Kathy, if you can again let me know what's in the chat. You don't necessarily have to, it's not that the image is necessarily right or wrong, but the image is there to really to give us a prompt as to the things to consider in a residential aged care setting that might help us prevent falls.
We've got low chairs, hearing and vision, shoes, walking aids, polypharmacy, medications generally. The coffee tables too low, chairs too low, lots around vision, which is great.
Yep.
Wearing glasses, footwear. Oh, there's a question about hip protectors. We will get to that one.
That's coming up.
Falls alarm, medication, continence with an exclamation mark. Oh, that's you, Kate. Very good. Door opening out, clutter, toilet, no support and too low. What else have we got here? Low light in the toilet, manual handling, the resident's cognition.
Yep, absolutely.
And pain. Perfect.
Beautiful, beautiful, fantastic. Thank you. All right, let's have a look at the recommendations. So we know that under Australia's aged care quality standards, all residents should have a comprehensive care plan that's developed on admission, and that should include a falls risk assessment and preventative strategies. And the evidence really shows us that when multifactorial programs are provided by tailoring carefully to individual needs and actively involving care staff, they're more effective. And this can be in both reducing falls rates and the number of residents who fall and sustain injuries. So multifactorial interventions, part of routine care. Individuals are regularly assessed, but environments are assessed as well. Developing the tailored fall prevention plan based on the findings of the falls risk assessment, and providing education and engaging the workforce about preventing falls and harm from falls. So you can see that that's a 1A, so that's obviously some very strong evidence there. The second guideline is really around looking at exercise, and among the most consistent findings in the research was the value of ongoing tailored exercise. So programs that are moderate or low intensity and delivered in a group by physios or trained staff were shown to reduce the number of falls that residents experience. For residents who can walk, they should have the opportunity to exercise, and it's encouraged for at least an hour a week. And also importantly, that residents with cognitive impairment who are able to participate can also benefit from these programs. So again, quite strong evidence there and strong recommendation. I think one of the key things with exercise, though, is that it needs to be continued. So measures like ongoing tailored exercise programs, they can significantly cut the risk of falls in aged care, but short bursts aren't enough. You can't just go in and do a 6-week program or a 2-month program and then a few months down the track expect that it's still going to be reducing falls. It just doesn't work that way. So we know that the exercise needs to be continued over time because otherwise you lose the benefits. Hip protectors. So this is a really interesting finding, and Kathy and I were having a chat about this, that the latest high-level evidence actually does suggest that hip protectors reduce hip fractures in residential care. So not going to reduce the rate of falls, but can reduce injury and the severity of injury. The benefits actually not seen in community dwelling older adults. So this is something that is at this stage consistent with residential aged care. But you know, as we know, real world impact is going to be influenced by things such as adherence, comfort, implementation, and that's obviously both with a resident, with family members, with staff, so that the controversy now, it's not so much around the biomechanical efficiency of the hip protectors, but it's more about implementation and adherence. You can see as well that the evidence is level 2, level 2A, so it's a weak/conditional recommendation, and obviously those are the conditions that we're looking at in terms of tolerance and preference around hip protectors and yeah, their use over time. Next, we have dairy food provision. So we know that in aged care, malnutrition has been found to be alarmingly common. And there was a recent study by Monash University which found that around 40% of residents are malnourished and 6% are severely malnourished. So we know that menus that provide sufficient protein and calcium are critical, and dairy foods stand out as a simple and effective intervention. The evidence tells us that menus should have around 3.5 servings of dairy food. And so that's things like milk, yogurt, and cheese daily. And the recommendation is around involving a dietitian in designing these menus to make sure that this happens and that can obviously help with the number of falls, but also with injury from falls. Closely related, vitamin D. So many older Australians in residential care do have low vitamin D levels, and that can affect muscle and bone strength. Again, the latest evidence found that the addition of vitamin D supplements proved helpful in reducing the overall number of falls. Daily or weekly dosing improves muscle function, and that obviously can help both prevent falls and fractures. The effect size of vitamin D alone is modest, and really the greatest benefit is where the baseline vitamin D deficiency is present, that the doses are more regular, so not large intermittent doses, and that it's part of the broader falls strategy and fracture strategy. So it's not a standalone fix. And I think that's one of the big things here is that, as we saw, there are so many different things that can contribute to falls, and therefore we can look at making changes to actually address those and hopefully reduce the falls. But it's not one magic fix. It's lots of different things, and it needs to be based on the individual resident. The last recommendation is around osteoporosis medication. So there is evidence of undertreatment of osteoporosis in older people in residential aged care. So we know that for people with osteoporosis or osteopenia, fracture risk increases with each additional fall. So it's really important that we don't wait for a fracture to check for osteoporosis, that all residents should be assessed. And in addition to osteoporosis medication, again, strategies for strengthening and protecting the older person's bones to reduce injuries from falls should also be implemented. So that includes improving muscle strength, enhancing nutrition, optimizing functional capacity, and improving the safety of the older person's environment. So again, multifactorial. A bit of a busy slide there, but this is just to bring us back to the aged care quality standards, to have a think about how these guidelines actually relate. So I'm sure you're all very familiar with the standards, but if we look at the different standards here, we can see how the falls guidelines actually can fit under each of these categories. So the individual, the organisation, we've got the care and services, as people have mentioned, the environment, clinical care, food and nutrition, the community. So obviously that's around ensuring that residents and families are involved in interventions and in decision-making regarding falls risk prevention strategies. Supporting transitions. So we know that transitions in and out of residential care are also a time of increased falls risk. So making sure that we're looking at things like handovers and discharge planning, admission and readmission and so on. And obviously recognising and respecting diversity and culture. But the falls guidelines also can be aligned with the Aged Care Act. So we've mentioned it previously, particularly with hip protectors, but also with all of the interventions, that the rights of older people need to be paramount. So safety first, dignity protected, and choice respected. That there are responsibilities of providers, obviously, to provide safe environments and safe clinical care, that falls should be reported, investigated, and that we really look at root causes in falls and avoiding and preventing falls, that the care is high quality, choice and transparency. So you can see there's a lot of overlap, obviously, with the aged care standards. The workforce, a strong workforce, staff to be trained, to teamwork encouraged, assist safely and recognise red flags. And then obviously that there's strong governance, rules and regulations that underpin falls and tracking data, sharing findings and strengthening governance systems. The aged care quality indicators is another area where falls is included. So we know that one of the main objectives in the indicator program is to give older people in Australia, residents and the community, transparent information around quality and aged care to assist in their decision making. I think it's important to remember that the collection and reporting of these indicators also provides residential aged care services with data to be able to measure and monitor their performance and support continuous improvement in the care that they provide. So it's actually a feedback mechanism coming back to you that you can actually use as part of your programs to be able to help prevent falls into the future. And the idea really is that if the output is around the effectiveness of falls prevention, and the input really is the falls guidelines. So use the falls guideline recommendations as inputs and the falls rates as outputs to evaluate the effectiveness of what you're doing. This is obviously, as you would be aware, the numbers that are provided. So we know that it's critical to routinely screen for falls risk and to monitor the outcomes of falls and falls prevention programs and interventions. So this is the data obviously that needs to be reported. But it's also important to remember that falls, as we keep continuing to mention, are influenced by multiple quality indicators. So there are direct influences on falls that have an immediate and measurable impact on fall rates. So that might be medication management or restraint practices. Haven't really mentioned that. But there are also indirect influences that also shape falls risk. So these are through the broader aspects of resident wellbeing and quality. So indicators such as activities of daily living, unplanned weight loss, incontinence care, hospitalisation, quality of life, all of these affect strength, nutrition, confidence and mobility. And that all can contribute to fall vulnerability. So again, these other areas can also be considered when you're considering falls prevention, and to make sure that you've got a whole of facility approach that integrates the clinical care with your environment, the workforce and your governance. So what can you do today to prevent falls? Well, as you can see, falls prevention, it's not optional. It's embedded across the Aged Care Act, every aged care standard and multiple indicators within the National Aged Care Quality Indicator Program. So hopefully the information that I've shared with you briefly today has already made you start to think about what you might do to prevent falls in your workplace. But I've got a couple of quick wins here that you can implement immediately. So have a look at your environment each shift. Encourage safe independence for the individual resident, reporting hazards immediately, encouraging that dairy intake, supporting exercise mobility, and observing and communicating changes in behaviour and mobility. It's a good start. But really the key messages around fall prevention is that it's everyone's responsibility. We know that all people in residential care are at risk of falling, but that the prevention strategies are effective when they're tailored to the individual. We need safe staffing levels, skill mix, education and teamwork in particular that supports good clinical care to prevent falls and to prevent injuries from falls. And that obviously it's important, therefore, to review and report every fall and communicate around the learnings that are found from that process. So in summary, really, falls prevention is a team sport. The guidelines are about action, not labels. And it's really around the small daily habits that actually make the biggest difference. And you can see here, I've got a link to the falls guidelines, but also a Cochrane review and a summary article of all the different strategies, which is really helpful if you want sort of a brief overview. And that is it from me.
Oh, and it's over to me, hey? That was awesome. Thank you, Amy. It was a great presentation and lots of food for thought. And I have seen that we've got a few questions that we will ask in a minute. Before we get to those questions, though, Kath, can you go through? Before we get to those questions, we will. And if you've got more questions, pop them in the chat so that we can see them and Amy can answer them. We're excited to let you know about 2 programs that we're launching soon that will help your organisation if falls is an issue for your organisation. One of those programs is an online programs for clinical leaders, 4 2-hour sessions where you work with Amy and you unpack your data. You think about best practice, think about what's happening on your site, and you can implement some strategies tailored to your site to reduce and minimise and prevent falls. The other program that we are super excited to offer is one-on-one support for organisations. So if falls continues to be an issue in your organisation, Amy, as a falls expert and improvement specialist, can work with your organisation one-on-one to really understand the root cause, to look at what strategies can be implemented, and to work with you and your team to bring people along with implementing those strategies. So we're super excited to announce that. Thanks, Kath. Again, while we answer questions, if you've got any feedback, you can scan the QR code and let us know. Otherwise, we will send you a copy of this recording so you can share it with your colleagues. There is a link to provide us with feedback or ideas on other webinars that you might like. And there's also going to be a link if you're interested in hearing more about these falls programs, either the group program or the one-on-one program. You can express your interest and we'll be in touch to talk more about how we can support you. So we'll get to the questions. There's a few in the chat, so we'll start with those ones. And then if you would like to ask any